Fawks. I'm a hospital doctor here. We don't directly work with you guys, but indirectly in the ER. I think you guys doing more ER and surgery and stuff like that. And I'm also the state surgeon in the Missouri Guard. Been in Iraq in 08, Afghanistan 10 and 13, and then somehow I got a rotation to Qatar last year. So I've seen a little bit. The Army's small, that's why I want you to have that card. I guarantee I'm going to be in for a while, and I have no doubt we'll cross paths. It happens all the time for no good reason. So the reason I want you to have the contact information, at any point from this point on, you need a letter, you have a question, I have no problem. If you guys say, hey, you gave a lecture, you saw me at Cox in Springfield, I'll write you a letter, or you can use me as a reference. I'm sure you have a lot of people, but I'd be glad to do it. Is this the thing here?
Yes, sir.
Okay. So we're going to kind of go through this. This is just different topics. You can ask questions at any time, and I'll kind of try to give you the down and dirty. So abdominal pain. The key to making any diagnosis, and ultimately that's what you need to do, right? You need to make a diagnosis. Any plan has to be predicated on knowing what you're treating. So you need to know anatomy. God only puts things in certain areas, okay? So if someone comes in with belly pain, the thing you need to do, they'll say, my belly hurts, you say, where? And you often say one finger. So people go, well, my tummy hurts, my belly hurts. Haven't put one finger on it. And then the other thing you need to do is you need to expose them. All right, so if they got a lot of clothing or body armor or something, probably not here. Not so much at Cox Hospital, but you need to look at their belly. You need to get an idea of what it looks like with your eyes and then where it hurts. You should have an idea of what's in those regions, right? Right upper quadrant, liver, left upper, what? Spleen, yeah. Right lower, appendix, and left lower is where the turds are at, okay? So that's the descending colon. So it varies. There are other weird conditions where things are flipped, but in general, that's, God only designs things a certain way. So just know the anatomy and have an idea in your mind, okay? You have a cheat sheet on you at all times if you can't remember, right? You are the cheat sheet. So you know what's in your own belly. You can think, okay, well, that what lives there. So oftentimes I'll say, well, the only thing this can be is this, because that's what lives in that region, okay? That's what I'll say. So and there's kind of layout of what it is, okay? All right, and this goes through a little bit. So in the regions, you can build a differential diagnosis based upon whatever problem they're presenting with. One thing to be aware of, because the diaphragm divides the abdominal and thoracic cavity, things in the thorax can present with abdominal pain. So if you have a lower pneumonia, the only presenting complaint might be abdominal pain. Okay, so think outside of where you're at and don't get necessarily hemmed in on whatever the issue is, but be aware of it. Heart attack can sometimes present with only intestinal or GI complaints. Okay, so listen to the story. In general, the patient will tell you what's wrong if you listen to them. Certain circumstances you can't. You just have to make a decision and move with it, and that's like many things I think you guys do. Sometimes you just make a call. But making a call is often better than not doing anything. In medicine, you have to make a decision. So make a decision and move on. And then reassess your decision, just like any other problem in life, okay? So we talked about looking at it, looking at the belly. A lot of people, that's what a lot of people are in South Missouri because of too much carbohydrates. They're distended. But if they're supposed to be scaphoid like you guys are, right? I'm not scaphoid because I'm in my 40s. Almost 50, so I'm not scaphoid. Scaphoid's like that, Their chesticles are bigger than their belly, so it's a little flat. If you laid a ruler, it would have a little space underneath it. Most people are like that. So you look at it. So lay them down flat and look at it. What do you do if you can't lay them flat? Do the best you can. Get an idea. Sometimes what I do when I talk to patients, I say, your belly looks a little distended. Is that normal for you? Oh, yeah, doc, it's always this way. Cool, no problem. Now I have a reference point. But if I'm laying them down flat looking at them, I kind of get an idea. If I see an area that's more distended, or maybe they have a bruise, then I'm thinking, based upon the history of what happened. Someone gets kicked or falls off a horse, and they got a bruise on the left upper quadrant, and it's kind of poochy, I might think of what? Spleen injury, yeah, or some type of problem. So you kind of get a look at it. And then you can listen. So normal bowel sounds, maybe nothing. And honestly, how many times do I hear anything of significance? Not very often. The classic would be high-pitched tinkling. In there's certain cases that might be a bowel obstruction. So you just kind of build this case, and you kind of get a sense taking the whole thing together. And then you palpate them. Now they'll teach you to put your hand, one hand and kind of push with the other. But I'll be honest, what I do is I'm talking to the patient and I'm looking at them and I'm palpating them all at the same time. So you can get this done real quick. You don't have to divide it up, okay? The best is just to work out something, a sequence that works good for you. Hey, buddy, what's going on? Your belly hurts? Does it hurt here? Can you point at it? Does it hurt when I poke over here, or how about here? You get what I'm getting at? Does that make sense? Okay. Whoop, hang on. There we go. So emergency situations you might think about. So these are air fluid levels. So that might be a bowel obstruction. Normally you shouldn't see all that. Okay, so if the bowel kinks, if they had surgery before, or if they're young and they have something called an intussusception, that might be bad. Or down here, this would be colitis, of course, bacteria, or they can get hypotensive with that. So these are emergency type things. But the wondrous thing, the first thing you should do when you see a patient is you should look at them and say, are they sick or not sick? That's pretty basic, right? So someone comes to you with a problem and they say my belly hurts, and you think to yourself, man, they look sick. Sorry, I said it. They look sick. They're not that sick. That already puts you in two different categories. So sick might lead you one way. They have a fever and they hurt in the left lower quadrant, and you look at it and it's poochy, and they're old, maybe they have diverticulitis. Or they don't look sick and they've been eating MREs and they're distended, maybe they're just constipated. Okay? Do you always need an x-ray to make a diagnosis? No. What do you need to make a diagnosis? Your ears, and your hands. That's really all you need. This that I have, this stethoscope, that's just for show. This is like the priest that wears the holy things around his neck at Mass. And this too, it doesn't matter. I could be, in scrubs, I could be anything, but this is my station right now. You guys can make the diagnosis with your brains and your hands. Any problem you're going to see in the belly has been there as long as there's been bellies. Does that make sense? So the stuff we see now is not new. There's nothing new under the sun. So you can diagnose these things. So think about that. Before I was a hospitalist, I was a country doc. So I was an hour and a half from anything. And I didn't have x-ray, I just had me. Okay, so guess what that sounds like? Being deployed to an austere environment where you don't have x-rays and specialists. So you guys can totally do this. All right, other things to think about, dehydration. What's that look like? Well, it's not a fat guy, it's a pregnant lady. So any woman that has belly pain is assumed to be pregnant until otherwise. You can ask her, when was your last period? Are you having sex? She could be a nun, but she still gets a pregnancy test. Just do it. It's okay. All right? Trauma and other stuff is all significant. So the real probably takeaway is if they look sick, they're probably something bad. They're hypotensive, they have a fever, they look like crap, probably that'll push you in one certain direction. They're tachycardic. Make sense? Okay. So here we're talking about GI bleeding. What was that? Yeah, we're talking about red flags. So GI bleeding now. So GI bleeding, we think about it with upper GI bleeding and lower GI bleeding. Those are the two biggest things. Upper GI bleeding, they're going to be coming in complaining of, they might say, I'm throwing up blood. And you say, well, how much blood? And they might tell you it looks like coffee grounds when they throw it up. Everybody's seen coffee grounds, right? You know what I'm talking about? Usually when they have an acute upper GI bleed and they throw up, it'll make you throw up. It's horrible. It really looks bad. And usually they look pretty sick. Lower GI bleeding may or may not be that big a deal. When they'll tell you, they'll say, I have some blood in my stool. Well, what do you mean by that? So you have to ask them, is it every time you pass a turd? This is what I say. Is every time you pass a turd? Is it on your turd? Is it in stool? Is it when you wipe? How many times a day are you going? Those are the things I ask. So you can take it wherever you want to take it, but you kind of get a picture of what's going on based on what they're telling you. Okay? What do you need to do if they're telling you they're bleeding from below? What should you do? And you really should do it if they have belly pain. I didn't say it the last time. You got to put your finger in it. If you don't put your finger in it, you put your foot in it, you'll miss stuff. So when I was in training, a resident 20 some odd years ago, I missed a uterine cancer in a lady that you could feel by doing the rectal exam. If they have an appendicitis, you can do it and poke to the right. Sometimes that will cause more pain, okay, because that's where the appendix lives. So when you do the rectal exam, one, you can put gloves on, do that for one thing. And you don't just put the tip in, you bury it, okay? Because you need to feel around. You need to scoop around and see what you feel. So if it's something, if you hit your finger on something, you pull it out and it's got brown stuff on your finger, what is it? It's poop. It's stool. Maybe they're constipated and maybe you need to dig it out. If you put your finger in there or if you look at their anus and there's blood coming out, that tells you one thing. If there's something that looks like a grape on their cornhole, what's that? Hemorrhoid. Okay, have you seen a hemorrhoid? It'll look like a grape. Okay, it'll look weird, it'll be painful when you touch it. If they've been passing hard stools and you put your finger in there and it hurts at a certain area, like it hurts at 3 o'clock but not at 6 o'clock, maybe they have a fissure because they've torn it. The other thing you have to think about is rectal foreign bodies, because humans put things in holes. So if they have a hole, they're going to put something in it on purpose or otherwise. So it's just doing a history and doing an exam. For an upper GI bleed, usually they're going to tell you about it or you'll see it, and then you just need to take it into account. If they're hypotensive, you give them fluids, isotonic fluids. If they really look sick, even without a CBC, you give them blood if you have it. Okay? You kind of divide them up again into sick or not sick. Okay? That's pretty simple. Sick or not sick. Any questions on any of that stuff? No? Okay. So as far as the differential, so you can kind of divide it again, upper and lower. So I kind of went into a little of it. Upper, esophageal erosions, when you look at them, it's actually eroded. People that would have that might have a history. Hey, doc, I've been taking a lot of ibuprofen because I'm trying to get ready for my PT test. Or around here, it's, I've been drinking a lot and I feel like I want to cut down on drinking, but then I started feeling sick and throwing up blood. Okay? So esophageal erosions or esophageal varices, and these are really the varices that are bleeding. Erosions would be more history of acid reflux, taking NSAIDs, that kind of thing, certain population, and then gastric ulcers. We don't see a lot of gastric ulcers anymore because, H2 blockers and Nexium and all that's over the counter. It's ubiquitous. Everybody takes them for whatever reason. When I was a young doctor 20 years ago, all that stuff was prescription. It wasn't over the counter. Okay, and we saw a little more GI bleeds. Years ago, before those medicines, you saw a lot of gastric ulcers, and people will tell you they had gastric surgery. Nowadays, we don't see it. But typically, these people, they'll come in just violent, throwing up blood. The worst ones are the alcoholics that have esophageal varices, okay? So again, it's history. Does that make sense? Okay. So if someone comes in, you kind of think, well, could this be an ulcer? Maybe they're hurting, throwing up blood. That will lead you one direction. Lower GI bleeding, you can have tumors. Pretty unusual, but it can sure happen. These are diverticuli. Have you heard about that, diverticulitis? So the lining the colon's made up of layers of muscle, and as people get older, and if they have a lot of stool that's causing a lot of pressure, then those layers can separate, and then inside mucosa pokes out between those layers. So if you looked at it from the inside, if you cut them open and looked at the colon from that area, it looked like little bumps on the outside. And from the inside, it looks like these little caves. So if they eat seeds or popcorn or stuff, they get stuck, they get infected. Classic presentation of that is, doc, I hurt on the left lower quadrant, and I got blood when I poop. Okay? So the problem when we try to diagnose that, if you go looking, many times that'll just close up on its own and heal. If it's an ulcer, it's not going to heal quickly. And if it's a cancer, it's not going to heal quickly. So those are all things to take into account with the history. This is inflammatory bowel disease or colitis. So colitis, like an infection, intestinal infection, that might be, hey, I'm out at this camp and we don't have good water, or I drank on the local water around here. Hey, I live out in Timbuktu and I'm on well water. You know what coliforms are? Coliform bacteria. It's poop in the water. So there's some people around here that are on well water where they would have an infection. But that story, if that was it, you'd have a history that would support it. I drank well water, or I ate at Red Robin, and then I got sick, had a fever, my belly hurts, and I'm pooping blood. Okay? So you kind of put that all together. So when you have these problems, come on in, when you have these problems, you just think about based upon your history. Okay? Here's some x-rays. So again, you don't have to make diagnosis of x-rays. What's this over here? What side of the body is that? Right side. So what's this? What's this? Yeah, so that's diaphragm. What's this under it? Well, it should be there, but that's air under the diaphragm because air is black. Over here, this is air in the stomach. That's called Megenblas. So air under the diaphragm on an upright abdomen is abnormal. So you got to think, what happened? Did they get stabbed? Because the abdominal cavity should be sealed, shouldn't have air in it. Did they get stabbed? That'd be a good reason. Did they get shot? Or did they perf their bowel from a foreign body or a diverticular? Okay. Over here you have air fluid. You have a stomach that's going up above the diaphragm, diaphragmatic hernias, and this is, again, another picture of that. So how often does this happen where the stomach goes above the diaphragm? Not very often. So hiatal hernia, pretty common. Traumatic rupture of the diaphragm from, motor vehicle accidents or deceleration type injuries or abdominal trauma, okay? Other warning signs, diarrhea illness, we'll talk about that. So this is my favorite movie and favorite picture right there. They'll be sick, okay, when they come in. Do you know what these are? Cholera beds, you'll see them in Africa, okay, where people just sit in bed and crap themselves. And you'll see, we saw a lot of things like this in Iraq and Afghanistan with the locals, okay? So diverticuli we were talking about, just a little picture of that. They're talking about constipation. What would lead to constipation? And that's what this is a picture of. This is all stool up through here. What are some things that can lead to constipation, and is it bad? Doc, I can't poop. Any ideas? Dehydration. Yeah, dehydration is a big one. Diet's another one. Medicines is another one in my population with chronic medicines that they take. Rectal foreign bodies. We had a person here in the ER that came in with a 10-inch dildo. He's been in there for 3 days, so he was constipated. That's what he came in with, and belly pain. So we had to do an exam, okay? So if you do an exam and something's there that God didn't put there, it's probably a problem, all right? So constipation is going to be a common diagnosis that will see. You just got to take into account. This x-ray, all this little kind of haziness, that's all poop. So this would be an FOS. You'd say this person's FOS, full of shit, okay? So when you evaluate constipation, if they don't look sick, remember I said sick or not sick. So if they don't look sick and they got a history that supports a benign issue, you just tell them drink more water. Or an old technique that I've used a lot is you give them a bottle of mag citrate. Anybody ever taken mag citrate? So it's an osmotic laxative. It pulls water into the gut, and they'll crap their brains out usually within 4 to 6 hours. So if you go to Walgreens, it's like a 10-ounce bottle, and it's an old-timey technique. So when I was a medical director in a prison and I had the prisoners come in complaining of constipation, I'd give them a bottle and tell them to drink it right now in front of me, and if they didn't like it, I told them to get the hell out. And in the Army, in deployed setting, I kept that around because that just worked really good, okay? The bad thing, if you ever take it, don't take it, and then the next day drink coffee and try to go for a run, because that happened to me one time. I was a little too far away. Bad things happened, because it really does work, okay? So just be aware of constipation. In your all's job, if you're acting as medics, for your people, just have something that you can treat them with. Usually it's just modifying their diet and drinking more water, okay? Not a big deal. Some old people will get all bent out of shape if they haven't pooped in a certain period of time. Reassuring them is a good way too. So not every time do you need a specific intervention. This gross look thing, do you know what that is? Says it right there, appendicitis. So that's actually a suppurative appendix laparoscopically from the inside. This is a fecal lith, so that's poop that's turned to stone in the appendix. So down here, right lower quadrant, that's a classic location of where someone will come in with an appendicitis. So the classic presentation is a younger person, high fever, sudden onset of belly pain, localized to that region. And I think it has a certain name, McBurney's or Murphy's Point. I never really, have you all heard of that? Where they'll push on it? When you evaluate them for an appendicitis, because a lot of people will come in, Doc, I got an appendicitis. Well, one of the things I'll ask them is, how was the car ride over? So if it didn't really hurt them, then it might not be appendicitis. If they say it was horrible, every bump I hit, I felt, could be. Then you have them get up on the table. If that movement hurts them, it could be. There's another sign called a heel tap test. Have you heard of that? Lay them flat, smack their heel, not just tap it, smack the shit out of it. And if that jostles them and causes pain, then it may be. And then you do the rectal exam. Any belly pain, if you remember this, do a rectal exam. You won't go wrong. Do a rectal exam on belly pain. So, I have, I told you a story about missing a uterine cancer. Lady presented with belly pain and constipation. I didn't do a rectal exam. I missed it. And I haven't told you all the in the wrong. Have you all heard back, George? You haven't heard the in the wrong story. So when I was an intern in Michigan, this old Polish lady came in with, rectal bleeding. I was going to do a rectal exam, and I missed the rectum and went into the vagina, and I missed twice. And eventually, on the third try, I got the rectal exam. She wasn't too happy. So the key to do a rectal exam, what should you do? If you're going to fire, you should always know your target. So make sure you see your target. Don't just fire blindly. Make sure you see your target, which is the rectum. Okay, looks like it's winking at you. All right, so do a rectal exam. This you won't see unless you're doing surgery, and not every appendicitis do you need to do surgery. That's another thing. What would you do if you could not evac your patient and you thought they had an appendicitis? Yeah, give them antibiotics and fluids and pain control and time. Okay, because how long have humans been having appendicitis? As long as there's been humans. Do they always need antibiotics? No, but now we know it helps them. So just keep that in mind. There's more than one way to deal with them. Pancreatitis. So where's the pancreas at? So the pancreas exits when the food leaves the stomach, it goes in the duodenum, right? And the pancreas is right there. So it's actually retroperitoneal. So if you put your finger right at their xiphoid and dove deep, that's where it lives. So if someone comes in with pain there and they're throwing up, they might have pancreatitis. Classically around here, it's going to be related to alcoholism. So usually they'll have a history that supports it. How do you know if a patient's alcoholic? They drink more than the doctor. That's how you know. So they drink more than the doctor, they're alcoholic. So they'll tell you, but most patients lie. So around here we joke you double what they tell you. So if they say I drink a pint, they probably drink a fifth. They drink 6, they drink 12 type thing. And they will have a certain look to them. What's this around the belly button? Yeah, colon sign. So that's intra-abdominal trauma, like right there, or in some reason. Gallstone pancreatitis, have you heard of that? So the gallbladder is right upper quadrant on the lower part of the liver, okay? And it holds on to bile. If you get gallstones, they'll go through the cystic duct into the common duct. Common duct goes through the pancreas. If it's too big and it gets stuck, or if it passes, it can irritate the pancreas. And they'll come in with those presentations, and they'll be pretty sick. You can do blood work and then show elevation in their amylase and lipase, okay? Steroids, sometimes if you get steroids, you can get pancreatitis. In your all's population, sometimes you see it if they're taking testosterone. So if you see guys, soldiers that are on IM testosterone, sometimes they can present with pancreatitis. Mumps, you won't usually see it around here, but that can present as pancreatitis. Around here in the States, it's with the Amish, but I have seen it in Iraq. So mumps in unvaccinated population. Malignancy, so pancreatic cancer, right? You've heard of that. That killed Patrick Swayze. He died of pancreatic cancer. That usually presents with no symptoms. It's asymptomatic. Scorpion stings sometimes can cause it. Fat, hypertriglyceridemia. So someone that's really well fed, or they're diabetic, or they have some other inborn error of metabolism, they can sometimes present with pancreatitis. So the pancreas's job is to help with producing insulin, and that's the connection there. Do you know what an ERCP is? As they run a scope through the mouth into the stomach to where the common bile duct drains is called the ampulla of Otter, and they try to pull a stone out, and that can cause trouble. All right? So this is supposed to be the pancreas all inflamed, like it really understand what that is. What's this right here? What? That's the liver, that's the gallbladder. Okay? So that's looking at the patient from the bottom. So that's the right side of the body. All right. So we kind of talked about it a little bit. Biliary disease, gallbladder, makes bile. You can get stones in it. Just because you have stones, is it going to cause trouble? No. Stones usually just dissolve and go away. But sometimes they will cause trouble, and then you can get an infection from bacteria. Here's the pancreas again, from the bacteria going up this common bile duct. All right? So classic presentation of gallbladder disease is the 4 F's. You know what those are? So I don't want to offend you, but I'm going to say it. Fat female, fertile, 40, flatulent. So if you got a lady in her 40s who's overweight and farting a lot, she might have gallbladder disease. So typically they'll come in with right upper quadrant pain. Sometimes they'll present only with shoulder pain. Doc, my shoulder's killing me. Or I hurt right at the point of my scapula. So you might think about that. So cholecystitis, usually they look sicker. They usually have a fever. Cholangitis, that's bad. That means this whole area is all inflamed. They're usually jaundiced because they have an obstruction, so the bile is backing up in their system. And if you look at their eyes, they're yellow. What's that called when their eyes are yellow? Icterus. So scleral icterus. So if you tell a doctor, hey doc, they have scleral icterus, I think they got an obstruction, they'll be like, that's cool, man. You know what you're talking about. You drop these words once in a while to the right people, and you gain street cred, because you're thinking the next step. Okay? But these people are usually sick. They have to go to the hospital, but usually it's older. People who have a stone that's blocked, that's my other favorite term, choledocholithiasis. They're usually sick, but not as sick as these guys. And someone that has gallstones may or may not be symptomatic. Does that make sense? Okay? So right upper quadrant pain may or may not be gallstones. To diagnose it, you can diagnose it clinically. Ultimately, we do an ultrasound, and then we correlate it with our history. So if someone comes in with pain, every time they eat a cheeseburger, usually it's fatty meals that make it worse because that causes the gallbladder to constrict. So they have pain, and we say, yeah, let's take your gallbladder out. There's another test called a HIDA scan, which is a nuclear medicine scan, and it has to do with how much squirts out at a certain time. And if that's low, we say you have a sick gallbladder and we rip it out. Okay? You guys might get to scrub in. Are you all scrubbing in surgeries? So you might get to see a lap chole. That's what they do anymore. And if you go into a lap chole, they'll dissect this out, and this is a certain triangle. You'll need to remember that. And in the middle of that triangle is the cystic artery, which you have to get a hold of. So you might get pimped on that and asked what that is. All right? So anyway, any questions on that? No, not a big deal. So right upper quadrant pain, sick or not sick, something different. All right, kidney injury. So with the kidneys, we divide it into before the kidneys, in the kidneys, after the kidneys, okay, when you think about problems, okay? What would be before the kidneys? Dehydration, right? So they come in, their heart rate is high because they don't have enough fluid, and their blood pressure is low, right? That's the compensation. Blood pressure is low, not a lot of fluid. Heart has to go fast to get what little fluid they have, move around. Usually, the way God designed it, they're thirsty and they're dizzy. Okay, and there's a history. Hey, I was on this ruck. I've been running. I've been working all day. Didn't drink any water. Does anybody drink enough water ever? Any of us? Nobody. Nobody does. Okay, so and you would think I would know better, but this past weekend I tried to do a hike with a friend of mine, 16 miles, and I fell out. It was bad. Shaky, tachycardic. It's horrible. I didn't drink enough water. I'm a doc and an Army guy. I still didn't know what I was doing. So pre-renal problems, usually they'll look like it. They'll be like, damn, this guy looks sick and he looks dehydrated. You look in his mouth, it's dry. His skin's tinting up when you pick it. You pinch him and it kind of tints up. And usually, what's the treatment for that? Give him fluid, right? So can you all start an IV? Every one of you? All right, what if you can't get an IV started and you think they need fluid? What? Drink, right? That's how God designed it. What else could you do? They can't drink, but you think they need fluid. Do an IO. What if you don't have that and you got an IV? Put it sub-Q under the skin in their buttocks. If you got a Foley, put it up their keister, right? Anything that goes in the mouth can go in the butt. I mean, that's silly, but really, medicines, fluids. So you can put a Foley in and put it in their rectum. Yeah, it happens. I'm telling you. So that's pretty silly, but so give them fluids. And then how much fluid do you give them? Enough fluid. You make the call. They'll tell you, check the radial pulse and all that other bullshit. You just give in young people, you're not going to give too much. In old people, you got to watch it, and you just give enough, okay? So some fluid's better than no fluid, really, okay? And no one should argue with you if you give too much because someone thinks it's too much. Just do the right thing. Renal problems, they're going to usually may or may not look sick, okay? So, you know, doc, I just feel bad. Maybe they have a history of diabetes and hypertension, and they take 3 or 4 different medicines, you know, glucophage and lisinopril, and then you do a blood test and their creatinine is, you know, 2 and their BUN's 50. So we do make a measurement between that ratio of BUN and creatinine. So if it's above 20, we say it's a pre-renal problem. If it's, you know, below 20 to 10, we usually say it's renal. Okay, does that make sense? So the BUN's 20 and their creatinine's 1, and they look dry, that's a pre-renal problem. Their BUN's, you know, 10, creatinine's 1, that's a renal problem. So it kind of just varies, but that's a good way to think about it. Post-renal problems, they'll come in with a distended bladder. In men, that's usually what you'll see, old men. And what would the problem be? What would be blocking their bladder? The prostate. Okay, if you did a rectal, would you feel it? Maybe. What would you do if you think it's a post-renal problem? Doc, I can't pee, I feel weak, my belly hurts, creatinine's all jacked up. What would you do? You think there's something blocking the urine getting out? Put a Foley in them. What if you can't get the Foley in? Yeah, you can do that, or you just keep trying. Have you put a Foley in? You all put a Foley in? So it's really easy in young people and in women. In women, the urethra's short. In old men, it's hard. Okay? And it's hard for me to do it, and then I have to call a urologist, and they use special things like rods, or they, you know, pull the penis one way and position the patient and jack around. So there's all sorts of things to think about, but there's usually only one way to go. Now, have I had patients put other things in their pee hole? Yeah, like psych patients and things like that. You know, so I had patients that put those little swizzle sticks down there, and there's some weird fetish thing where they rod their prostate. They like put glass rods in them. So you kind of got to know the history too. Okay? What's another thing that could block urine getting out? Kidney stone, pretty unusual, or a bladder stone or a bladder mass. So bladder mass, so you might have blood, stuff like that. So it's all history. All right? But if it's a post-renal problem and you unobstruct them, even if they're in renal failure and they're sick, they'll get better. You won't have to do anything. You've, you know, set up the normal physiology. In pre-renal problems, usually you got to give them fluid, and in renal problems, may or may not need to give them fluid. Sometimes that's just how it's going to be. You know, with the renal issues, if they're on medicine that's jacking with their kidneys, not giving their medicine is going to be effective. Okay? Usually those people need to go to the hospital. So that's that. This, who knows what that is? That's all like polycystic kidney disease. It's all kind of gross. So uremia, people have uremia. That's a buildup of that, you know, blood urea nitrogen. It's supposed to be in the urine, but it's in the blood. Those people look sick. Sometimes they can have, you know, heart issues because you'll have uremic syndrome involving the heart. And hyperkalemia, what would you see with that? Yeah, spiked T waves. So you do a, you know, EKG or put them on the monitor, and you're like, man, that's jacked up. I wonder what their blood is. Okay, so you kind of take it. Nephrotic syndrome, that's where they're dumping protein in their urine. Those are usually diabetics or they have other issues going on. Okay, all right. So just think about that in general. UTI, usually got a history. Frequency, burns when I pee, and usually women, usually younger women. Like, anybody have kids? Y'all have kids, daughters? Daughters, yeah. So they wipe the wrong way, and you got to teach them. So men can get UTIs, but it's unusual. Usually it's older men if they're going to get them, or they're putting their pee hole someplace where there's poo, or they're putting something in their pee hole. So if you get a urine culture on a dude and he has E. coli in the urine, you might have a conversation about lifestyle. Not making a decision about it, but you just need to know what's going on. Seriously, that's like real stuff that's happened to me. Because it's not designed for that to happen. Or you think about something else. What if they got E. coli in their urine and they've had abdominal cancer and they're getting radiation? Maybe they have an enteric bladder fistula where their gut has adhered to the bladder. Now they got poop coming from their gut into their bladder. So something else weird is going on. Or they have prostatitis, prostate infection too, which can present as UTI. So if it's a dude, you kind of think about it more. If it's a lady, you just treat it. So do you need to do a UA on every lady that comes in with classic urinary symptoms? No, you just treat them. Do you need to give everyone antibiotics? Not all the time. Sometimes you just give them fluid and educate them and Tylenol and pyridium and they do okay. But so you just kind of have to have an idea of what you would do, all right, in the right situation. For me, sometimes we do a lot in the civilian world just so the perception is that we're doing a lot. But maybe in your world, you don't have to do that. You just treat them or tell them to get lost, go drink water, take an E, that kind of stuff, okay? All right, so, hello. So you can do the urine dipsticks, but I'm telling you, sometimes you can just do by history. If you do this is nitrate, that stuff only comes from bacteria, right? So if you see that, it's probably bacterial. If there's leukocytes, which are also called what? White blood cells. So that's called pyuria, pus in the urine. Doesn't necessarily mean it's from an infection, but it could be. And then hematuria, where's that at? Hemoglobin? Anyway, so if they have blood in the urine. So classic UTI, hematuria, pyuria, and nitrites, okay? All right, glucose, if they're jumping sugar, they're probably what? Diabetic. So, doc, I drink all the time, and I'm always thirsty, and I'm peeing every time I turn around, I'm losing weight, probably diabetes. All right, any questions on that? For a prostate infection in men, what's the classic presentation? Yeah, there's a peeing a lot, and they'll tell you, I feel like I'm sitting on a sharp stick. And you'll say, is it right behind your balls in your taint? This is me. I'm not making this how I talk to people, because that's what people understand. Do you feel like you're sitting on a fence post? Yeah, doc, I really do. Probably got prostate infection. Let me do a rectal exam. I push on it, it hurts. Probably prostatitis, I treat them. Okay? So this, if it gets bad and they have pain up the backside, what's that called? Flank pain, Lloyd's sign. You pound on the backside and it hurts, and they got a fever. They might have pyelonephritis. So UTI, urinary tract infection, broad term. Cystitis, just the bladder. Pyelonephritis, kidney, okay? Pyelonephritis, they look sicker. Make sense? And we talked about the EKG. Dialysis, pretty sick people. Even for me, it's a lot going on. Have you seen dialysis before? It's a big machine. They literally suck the blood out, run it through an osmosis filter, and draw out all the stuff. Those people are a whole different ball of wax. All right? Strokes, thing to know that we're only designed a certain way. So there's usually a cross. One side controls the other side. So if they come in with facial droop on one side and weakness on the other side, may or may not be a stroke. Usually you go for you want symmetry. So you ask them, smile, stick out your tongue, and you're doing that while you're having to squeeze your fingers, push your feet down, that kind of stuff. Does it present, do they know what's happening? Not all the time. Sometimes they wake up with it, or they'll have a headache or something. So have you all had a chance to see stroke patients here since you've been here? So you might in the ER, okay? So ataxia, they have difficulty walking. So doing a quick neurological assessment head to toe, hey, how you're doing? They're talking to you, and they make sense. That's good. Stick your tongue out, smile, open your eyes, shrug your shoulders, that kind of stuff, okay? And then this is the sequence you run through. If you think it's a stroke, on the civilian side, you get them to the hospital as soon as possible, and we do a CAT scan. We use thrombotics, okay? If they have a bleeding problem, we don't do that. And it looks like that's it. Do we got test questions to go through?